and access to share.
Awesome. I will say, everyone, that our wonderful Suzanne is with us today and is also getting to be on aunt duty in Denver, Colorado, providing in-person postpartum support. So we have our slides up. And Nkechi, I am going to turn it over to you for introduction. And then again, everyone, just as we go, put your questions in the chat and we will open up for conversation after the presentation. Nkechi?
Hello, everyone. My name is Nkechi Charles. I am part of the fourth semester team, and I'm so excited to have Burcu present to us. She has done an amazing work. I do ask for your forgiveness for technical difficulties. I had to change locations, but I will be sending in the chat our attendee forms so that we can be able to collect that information for our reporting. And please feel free to ask any questions, and we will keep an eye on those during the chat. And so, Burcu, may I give it to you?
Of course. Can you all hear me okay? It seems.
Yes, you sound great.
Great. All right. Hello, everyone. Thank you so much for being here today. My name is Burcu Bozkurt. I guess I'm a PhD grad. This is my first presentation as a doctor. I graduated from UNC's Department of Health Policy and Management, and I currently work at CareFirst, which is the local Blue health plan up in Maryland. And I'm excited to present to you my labor of love for the last 2 years, my dissertation work. So I'm going to quickly provide an overview of the research. The research itself focuses on Black-white racial disparities in the United States and in North Carolina. I'll set the stage for you about why this matters, why the postpartum period is important in the context of overwhelming Black-white racial disparities and maternal outcomes, and then I'll kind of cover each of my aims. And really focus on the last aim, I think, which has the most direct implications for community-based practitioners. I'm happy also to take questions, and we'll look to the team to keep me on track with regards to getting to all the questions in the chat. All right, so in the spirit of self-reflexivity, I do want to start by acknowledging my standpoint as a white passing researcher. That means that I do not have personal experience navigating the healthcare system as a Black person. I can only share what Black postpartum people qualitatively shared with me because I did not have full access to the discourse that may happen when racial concordance is achieved between Black communities and researchers. I will say I'm a childbirth doula and I'm a certified childbirth educator. Due to these roles, I have observed the interactions between Black birthing people and healthcare workers in North Carolina. I've advocated for Black people and families in those spaces. And in the process of working on my dissertation, I made sure to pursue further racial equity training to build my own capacity to be a thoughtful navigator of spaces that aren't culturally my own. Also, in the midst of this work, I gave birth and became a postpartum mother myself, which was disclosed to the research participants at the time. So, of course, my positionality influenced this research to some extent, and I encourage you to view my findings and engage with this research with that in mind. Ready? All right, so as many of you already know, the United States faces a critical maternal mortality crisis. Non-Hispanic Black birthing people are 3 to 4 times more likely to die in pregnancy-related death compared to their non-Hispanic white counterparts. I know I'm preaching to the choir here. This is the largest disparity among all conventional maternity care measures we have available by far, and was the focus of my dissertation. I've seen late-breaking data that this is actually changing a little bit to that different demographics are also spiking here. So something to keep an eye on. Let's double click on North Carolina for a second, which ranks as one of the bottom 20 states in the country for maternal mortality. Postpartum birthing people in the state are nearly 2 times more likely to die than their white counterparts. And as you can see at the bottom of the slide, the postpartum period is a critical time. More than half of maternal deaths occur in the postpartum year. Most of the deaths are preventable, and a significant portion of severe maternal morbidity events, medical events that lead to short or long-term consequences for birthing people, occur after birth. But our traditional approach to the postpartum period is lacking, to say the least. On the top of the slide, some birthing people receive a postpartum checkup at the 2 to 3 week mark. Most birthing people know of and receive the 6-week postpartum visit, and many times it's insufficient. It occurs too late to prevent any common postpartum complications, and is too infrequent and too early to provide support to birthing people during the postpartum year, when many physical, emotional, mental changes are still taking place. Here's an illustrative example of what might be taking place for a birthing person after birth. Look at all the physical and emotional changes that we've denoted here on this slide. For example, while postpartum depression might develop by the 6-week mark, many birthing people don't develop PPD until 6 months or later. If the birthing person chooses to exclusively breastfeed, they may be focused on getting into that rhythm for several months. Things like physical, mental exhaustion, sleep deprivation as they take care of a newborn, it's clear to see that birthing people just don't miraculously stop needing additional support, care, guidance after 6 weeks. So it's why high quality postpartum care tailored to each birthing person is so, so important. Care during this time is an opportunity to assess the birthing person's physical and mental health, connect them to future care, as well as provide critical social support in the form of information, encouragement, and time. And so we know that existing literature has already established that access to postpartum care offers known benefits to birthing people in the form of better outcomes, improved well-being, and cost savings to the healthcare system. And yet, despite the known benefits, we know disparities are prevalent in postpartum care utilization, access, and quality. As many as 40% of birthing people do not report for a postpartum visit in the 3 months after birth. What happens inside those healthcare encounters, what care and guidance is delivered, and how, are also really variable. So clear understanding of postpartum care disparities is key to informing future policy and intervention efforts. And we know that those efforts should be designed to ensure successful implementation. So that means high quality care in the upper left, in that all that recommended care content, things like nutritional counseling, postpartum depression screening, are delivered to all birthing people. And this means highly consistent care, timely, person-centered, equitably accessible, and utilized by all birthing people. So my dissertation was designed to fill some gaps in our understanding of the consistency and quality in postpartum care utilization. So I'll talk a lot more about this. No need to get into the details, but in aims 1 and 2, I quantified Black-white disparities and aspects of postpartum care. And in aim 3, I used qualitative methods to explore postpartum care needs that Black birthing people have across time. So my first 2 aims, when I say quantify disparities, what does that mean? In health services research, the way we operationalize disparities in terms of like what variables we use in our models and how we treat them is really, really important. So I use the Institute of Medicine definition of disparities as a framework for my methodological approach in my first 2 aims. So take a look at the bar graph on the left part of the slide that shows healthcare expenditures between Black and white birthing people. That's just going to be our main example here. The IOM definition differentiates and parses out what is just and unjust differences between these 2 groups. So the IOM definition is unique in that it defines disparities as differences in healthcare use that are not due to differences in underlying healthcare needs or preferences. It's captured by the disparity bracket next to the red box. And so unjust differences, according to the IOM definition, are in the red box. These disparities include things like differences due to socioeconomic status, differential access and impact of healthcare systems, and discrimination. And just differences in healthcare are outlined in the green box. So things like need for care, health status, preferences for care. These are defensible explanations for differences in healthcare use per this definition. So to implement this, we adjusted for health status variables between our groups, the green box, but not socioeconomic related variables, the bottom red box. So this is a little bit of an overview of the adjustment process. Pretend we have health status distribution, how healthy people are, the dots on the right of the slide. These distributions are different between Black birthing people on the left and white birthing people on the right. So what we do is, we estimate the model for what we're interested in observing. Here, let's say total healthcare expenditures. And then we adjust the health status distribution for the Black group to match the white group with a unique method. And effectively, with that transformation, we're asking, what would the rate of healthcare use be like for a group of Black birthing people who look as healthy or who have the same health status as those of white birthing people? And so now we've created a hypothetical Black group with the same health status distribution as the white group, and then we calculate our model. So here's the information about my kind of data sets and samples for both aims. For aim 1, we use this really rich data set called MEPS. MEPS stands for Medical Expenditure Panel Survey. It's nationally representative. It has really rich socioeconomic health and healthcare variables. Oh, do I have a question?
No, you're good. Just keep going.
Okay, great. Sorry. My reason for using MEPS was precisely because we could use those rich variables linked with healthcare utilization. So I could implement this method I just talked about. And it also aligns with our kind of broad definition of postpartum care use that we used in aim 1, which was all healthcare use in the 1 year postpartum. And for my second aim, the second column, I use the Pregnancy Risk Assessment Monitoring System. I'm sure many of you are familiar with PRAMS. We focused in on North Carolina for this study between 2016 and 2018. And this allowed us to look inside the healthcare encounter. So 1, it helped us see whether birthing people reported receiving a specific postpartum checkup visit. And 2, it allowed us to see the disparities and the comprehensiveness of that postpartum care. What I mean by that is PRAMS asked questions to birthing people about whether they received each of 10 recommended postpartum care components. And so we were able to leverage that data. So for our first study, our data set represented about 2 million birthing people. And for our North Carolina study, we represented about 250,000 birthing people in the state. And then a little bit more information about my kind of main outcomes. My first aim, I looked at total medical events and expenditures. And here's kind of our approach. And then here are my findings. So you can see results from my kind of disparity models in the red box on the right. First, I found statistically significant Black-white disparities in total inpatient expenditures and total postpartum expenditures, in line with some of our initial hypotheses that Black birthing people would have less overall expenditures in the postpartum year. So this is a concerning finding, given that a significant portion of maternal mortality and morbidity events occur in inpatient settings. Disparities that we found here are likely to signal access challenges. Interestingly, I also found that Black birthing parents received more care or spent at a higher level than white birthing people in our sample in office-based and outpatient sites of care. So possible explanations for this having, for Black people having significantly higher expenditures in these sites of care include that they may prefer or favor these settings of care during the postpartum year, or they have higher access to these types of care more than other settings. And then in AIM-2, as a reminder, we focused in on North Carolina and looked at disparities in birthing people receiving a postpartum visit and then care during that postpartum visit. So you can see my main variable of interest was race again, and how I kind of managed each of our variables in accordance with our method. And here's what we found. So first, I'm just presenting, this is unadjusted data, no models, just descriptive. So compared with white birthing people, lower proportions of Black birthing people reported receiving a checkup visit, but this difference was not statistically significant. Among those who reported receiving that postpartum checkup, Black birthing people self-reported receiving significantly higher total postpartum screening and counseling components. So contrary to what we thought. So our full AIM-2 findings, this is our kind of models. Above the red boxes, I'm also showing some other ways that health service researchers commonly calculate disparities with the same sample. And our main disparities models are in the red boxes. So contrary to our hypothesis, we did not find any statistically significant disparities in the receipt of a postpartum checkup visit between Black and white birthing people in North Carolina between 2016 and 2018. In fact, we found that among those who received a postpartum checkup visit, Black birthing people were significantly more likely to receive an additional component of postpartum care counseling or screening than their white counterparts. So interestingly, these findings align with recent studies using PRAMS data, which find that while patients of color had lower proportions of accessing that postpartum checkup, white birthing people were counterintuitively less likely than these groups to receive recommended counseling and screening. So providers, a possible explanation for this is providers may be aware that these populations are at higher risk for adverse maternal outcomes and are kind of adjusting their behavior accordingly in better targeting and doing outreach to Black birthing people around these care components. Do note, however, that the difference here is incredibly small, and so likely not clinically that important. Overall, the picture is quite grim. We're still predicting that Black and white birthing people receive about half of the postpartum care content they should be receiving. All right, now the interesting stuff. My third aim, I explored change and how Black birthing people experience navigating their health needs and social environment over the course of the postpartum year in North Carolina. So here I employed longitudinal qualitative methods intentionally to explore change across time. The postpartum period is not a static force. It is a multifaceted, dynamic period, and our methods should be appropriate to that time period. Using longitudinal qualitative methods here provided really incredibly rich contextual depth of birthing people's experience across time that we simply can't get at with quantitative data or even, one-time interviews with Black birthing people or Black postpartum people. So for this aim, I interviewed the same 11 postpartum Black birthing people across time, 4 to 6 weeks apart. And I complemented this with 11 semi-structured provider interviews who had in-depth knowledge of women's postpartum needs to add kind of contextual insight and depth. And in the second part of this aim, we extracted postpartum needs from these interviews with Black birthing people. So whenever a Black birthing person said, man, I would have really liked XYZ, or XYZ would have made my experience much better. We took all those constructs and we fed them into an online concept mapping exercise with diverse maternity stakeholders in North Carolina. So the goal of that was to conceptualize and prioritize services based on what Black birthing people are telling us they want, and what their most salient needs across time are, with potential recommendations and actions. So overall, we conducted 44 interviews, and our online concept mapping engaged 16 maternity stakeholders. Multi-pronged recruitment strategy. We used a website, social media. We put up a print poster in churches and health departments in 2 geographic areas in the state. So we conducted the 44 interviews all virtually. So each 11 Black postpartum person was interviewed 3 times. And we had 11 additional provider and birth worker interviews. A majority of our Black postpartum participants were married. 7 of them were on private insurance, 4 of them on Medicaid. We had good geographic coverage for these 11 people. Of our 11 providers and birth workers, 4 were OB-GYNs, 7 were nurse midwives, and 2 were also doulas. 5 providers, birth workers identified as Black, and 6 identified as white. Analytically, we used the public health critical race framework to frame the study. We integrated the new disparities research framework from the NIH that gave us some good socioecological leveling for our analysis. And my analysis took into account the longitudinal aspect of our interviews as depicted on the right part of this slide. So we created cumulative memos and field notes. We built from one interview to the next with the same Black postpartum participants, and we managed this data chronologically. So we also used something called framework analysis to highlight concepts that influenced relationships between different time points. We uncovered 5 themes central to the lived experiences of Black postpartum people during the postpartum year, complemented with perspectives from providers and birth workers. So if you have zoned out until this part of the presentation, if you take nothing else away, now's the time to hone in and look at these themes. So first and foremost, Black postpartum people described coping with implicit bias, discrimination, and racism throughout the postpartum period. Black postpartum participants shared accounts of negative interactions in the healthcare system, which a majority explicitly associated with their race. The quote on the left from a postpartum participant speaks to the types of stereotypes that Black birthing people had to battle in healthcare settings. Providers validated witnessing various ways in which Black postpartum people were judged, labeled, or treated poorly or inequitably, which the quote on the right speaks to. So I'll give you all just a second to take a look at these. I'm going to take a look at the questions too. Okay, no questions yet. All right, our second theme, a majority of Black postpartum participants talked about enduring physical pain and unresolved postpartum symptoms across months. Interviews often either normalize these experiences or frequently prefer to forego interactions with the healthcare system. Coupled with not being taken seriously and ignored by their providers, our findings point to a trend of unmet medical needs and inadequate anticipatory guidance over time that are just insufficiently addressed by the current postpartum care paradigm of 1 visit at 6 weeks. So take a look at the quote on the right. I feel like I've kind of been like tossed and turned. My blood pressure will be taken and they'll be like, okay, well, as long as you don't have a headache or you're exhibiting any other symptoms, you should be okay. I'd really just like for that to be taken more seriously. The quote on the right, we give postpartum patients like this pamphlet and this handout and this log, and all the numbers are there if you want to hurt yourself or if you can't breastfeed. When you don't even shower on some days, when you don't even know what day of the week it is sometimes, we literally expect them to find that book, admit to themselves that they need some help, and call the number. We're fooling ourselves. Theme 3. The third theme of our analysis sheds light into the emotional labor Black birthing people take on in the process of finding new stability and reinforcing their autonomy across time in the postpartum year. So in the healthcare context, this meant that they have to advocate for their preferences and for better care to secure and protect their physical and emotional well-being. Black postpartum participants generally describe needing to advocate for themselves in interpersonal relationships initially, and then within larger societal institutions later on in the postpartum year as they went back to work, for example. Black postpartum participants also discussed the emotional labor involved in asking for support and negotiating the necessary time and space to reinforce their bodily autonomy. So notably, Black postpartum participants described a near constant need to advocate for themselves in healthcare settings and explain the ways in which their healthcare interactions almost always added to the emotional load they were carrying. The fourth theme of our analysis described how Black birthing people work.
Could you go back and maybe read those quotes? Because they're so cool. Yeah, thanks.
In your head is, you really should have asked for that thing instead of just like going with whatever they're saying. Then like being conditioned to not push back. And then if you do push back, make sure you have everything lined up so that you can for sure prove it and make sure that you're taking the emotion part out of it. And then the second Black postpartum participant said, I recognize all the complex history of breastfeeding with Black women because of what it meant historically, that sometimes Black women weren't able to feed their own babies because they had to feed white babies. This idea of like your body not being your own, your body not being for you, like Black women being used just as a source of food and, you know, being a wet nurse and having that be your identity, not by choice. The fourth theme of our analysis described how Black birthing people work to right-size external support to their dynamic needs throughout the postpartum year. So our findings put forth a more nuanced picture of social support processes Black birthing people undertake across time. Black postpartum participants in our study drew immense emotional, material, and social support from their families and extended communities, but experienced waning support after the initial postpartum months. Many Black postpartum participants also attempted to attain external support from mental health professionals, lactation counselors, and doulas, and noted access challenges to these professionals. For Black postpartum participants, these social processes securing external help coincided with really complicated feelings around vulnerability, self-reliance, and a lack of trust in external help. So on the left, a quote from an OB-GYN, with mood or lactation specifically, there's a really awful gap in our training about how to adequately address those postpartum issues. We can address bleeding, we can address pain, infection, but we're not well trained to address lactation or mood. And I think those are some major issues postpartum that would otherwise be addressed after 6 to 12 weeks. The quote on the right from Harriet, these are all pseudonyms, by the way, Black postpartum mom who was 2 months postpartum. Because everybody's so short-staffed, it just felt like there was no care. We had a lactation specialist come in. I don't want to beat on everybody. There was some that took more time. I wish there was a standard because it just seemed people chose what they wanted to share, how they wanted to share, when they wanted to share. I really valued being able to go to a lactation specialist afterwards. We spent an hour there. The last theme of our study explored the ways in which Black birthing people sought safety for themselves, their infants, and their families. Black postpartum participants used multiple strategies to seek or create safety for themselves in healthcare settings in which they reported feeling hypervigilant, anxious, and fearful throughout the postpartum year. Postpartum participants sought safety by doing research before their appointments, asking many, many questions, signaling their privilege, and attempting to personally connect with their providers. Next, Black postpartum people sought safety for themselves by pursuing culturally congruent services where they could, finding Black childcare providers, Black healthcare professionals, and securing better financial health for their families, which led to moves and new jobs. So the quote on the left, really jarring, from Nikki, who was 10 months postpartum when I talked to her. I had a 3rd-degree tear, and so that made my recovery really painful and like bad. I'm a single mom, and so I'm the only one who can provide for my son financially. And so I had to get back to work pretty soon after giving birth. I had him on a Wednesday. We were discharged on a Friday, and then I was back to work on Monday. So yeah, it was bad. On the right, I found myself in that situation, like trying to find ways to like overly try to connect with the doctor so that they would be more connected to me, to be more willing to care, to make an additional check. If I can feel connected to you, then hopefully you like think more critically about the services I may need. So then sometimes I'll wear, like I went to X university, so I like wear that school shirt. Moving on to our concept mapping, we recruited 16 stakeholders involved in maternal health care and policy in the state via purposive sampling. We mined all transcripts from our longitudinal interviews with Black postpartum people for need statements, resulting in 89 discrete postpartum needs. You can see what these look like on the right. We asked participants to sort each need into conceptually similar piles and to name each pile, and finally to rank each need on relative importance and actionability. I won't cover concept mapping analysis in full detail here, but it essentially entails figuring out how frequently certain things were grouped together and then mapping those out into a two-dimensional map. And then we apply, cluster solutions to that map, and we pick a handful. It's kind of an engaged process. We pick a handful to present back to the people who participated, so they pick the most appropriate solution. Here's what this looks like. So a mixed group of investigators and concept mapping participants discussed the pros and cons of each of the solutions we presented. And ultimately, we selected the 10 cluster solution due to its relevance for stakeholders in the state who would ultimately use recommendations mapped to each cluster. The group also renamed each cluster, a process that was supported by the software program that we used. Lastly, during these discussions, we captured recommendations from key stakeholders, which are summarized in a table alongside each cluster. I'll show you that in just a second. So the final concept map contains 10 clusters. 1, investing in a culturally congruent workforce. 2, anchoring care team, meaning like the team that's around you for birth and postpartum, into a human-first approach. 3, refreshing the postpartum care priority list. 4, broadening the boundaries of comprehensive postpartum care. 5, diversifying postpartum visit options, meeting postpartum people where they are. 6, bolstering family financial literacy and well-being. 7, supporting healthy community connections. 8, ensuring access to postpartum mental health resources. 9, guiding through postpartum emotional and social changes. And 10, disseminating anticipatory pregnancy and postpartum guidance. When selecting the final cluster map, we also decided to make a few adjustments, and we note those in our study. So the key insights, if you're kind of taking a step back and be like, whoa, what are these groups? What do they mean? Starting with the red box on the left, our findings emphasize that meeting the psychosocial and emotional needs of Black postpartum birthing people is a crucial aspect of improving their experience in the postpartum year. So this, sadly, is insufficiently addressed in current clinical settings. Our findings also underscored the key theoretical distinctions that have significant programmatic and policy implications. So for those of you in health systems, for those of you in community-based organizations, here's something to take away. Diversifying the birth workforce to better meet Black postpartum people's demands for, culturally congruent care is separate, but must go together with efforts to improve the soft skills of providers and birth workers around how to treat and take care of minoritized birthing people and their families. So those two things are separate but equal. They must go together. Expanding postpartum visit options to offer more flexible postpartum offerings and meet Black postpartum people where they are is different than efforts to broaden comprehensive postpartum care to create more space for Black postpartum people's voices and emotional needs. One of them focuses more on, let's try to find ways to get postpartum care to Black postpartum people. The other one focuses on, let's try to enrich the things that we are able to offer Black postpartum people. And we also mapped everything into a go zone graph based on their importance and actionability ratings. So the green box on the upper right represents needs that stakeholders said are both highly important and highly actionable. So if I were, devising a strategy to tackle postpartum racial disparities in North Carolina, I'd start with the red box, or with the, green box. These needs mostly belong to the 3 clusters that I've listed on the slide: anchoring care team into the human first approach, refreshing the postpartum priority list, and broadening the boundaries of comprehensive postpartum care. There were also some postpartum needs that were rated high in importance, but low on the actionability scale, such as being able to attend postpartum visits on short-term notice to address issues impacting my quality of life, and attending postpartum visits where I did not feel rushed. And lastly, we use multiple focus group discussions to solicit recommendations for health systems and for state policymakers in North Carolina from our stakeholders. So these are the first 2 clusters with the kind of highest importance ratings that I'm showing here. We have 10 of these. And of course, these discussions led to really unique and important insights about where health systems and policymakers should act to meet Black postpartum people's needs in that postpartum year. And of course, as with any research, there are limitations to this work. I'll touch on a few from the slide. Our models in my first 2 aims that were kind of quantitative don't adjust for what Black people actually prefer. We don't have good measures for that data in our data sets. It's not general practice right now to ask patients what type of care they prefer. So that means that we're not fully aligned with the Institute of Medicine definition of disparities. We're adjacent. It's the best we can do with the data we have. Our geographic variables for both were also really limited, of course, to protect the privacy of those participants. We know that much of healthcare is local, so it's a limitation that we need to keep in mind. And in AIM 3, our total study enrollment period for Black postpartum people spanned like 9 to 13 weeks in total, which is obviously just one slice of the postpartum year for any given person. So even though we had coverage from the entire year, representation from the entire year, we didn't get to see contextual mechanisms for the entire year for one individual. And then overall implications. So much of the policy work around maternal outcomes in this country, of course, has focused on expanding Medicaid coverage to postpartum people. That is all well and good. That's good. We should do that. But it's just the beginning. So lower inpatient expenditures for Black birthing people in the postpartum year, indications that postpartum people overall are receiving about half of the postpartum care content that's recommended. And my qualitative data speaks to suboptimal implementation of postpartum care. So more needs to be done to provide more person-centered, culturally sensitive care alongside more comprehensive supportive policies. Second, health systems are key in care transformation. The findings from AIM 3, those interviews, had the most clinical relevance. That had the most clinical relevance were those that signaled, however present, the consequences of racism, discrimination, and implicit bias are for Black postpartum people as they navigate the healthcare system. So health systems need to prioritize efforts to improve cultural competency of their staff and transform kind of the inequitable body language of the way we deliver care in this country. And last, our findings showed that appropriate postpartum support of Black birthing people transcends traditional healthcare services. We need to enact policies to help strengthen the social support infrastructure for Black birthing people. So that's my presentation. I know we have about 20 minutes left. I would love to take any questions at this point.
Well,
Thank
thank
you.
you. And Ketchy?
Yes, I just want to say, yes, thank you so much for this great presentation. We do have a question from Tiara Morris. Tiara, would you like to go ahead and go on camera, or would you like me to ask the question?
Hi, I just wanted to know, were there any other, I did get on late, so my apologies if this was answered already. But yes, I just wanted to know, were there any women of color who were a part of the data collecting part of the study?
Yeah, no, that's a really good question. I started at the beginning. So I was able to attain some funding to have a student of color analyze the data with me, but I couldn't get enough funding to like invest in a person of color to collect the data. So this was something I started out all my interviews with, in terms of acknowledging with each interviewee that I was a white passing person and I was going to follow their lead with regards to what they wanted to share with me. But certainly a limitation of my work. Yeah, I put that front and center. Once I'm not a poor PhD student, would love to expand my capabilities there. Thanks for the question, Tiara.
Does anyone else have any questions?
There's one in the chat. What would be the best way to educate healthcare providers on how to be more culturally aware when caring for people of color?
That's a great question, and not something I particularly looked into. Now, we know the data is pretty split there. You see a lot of health systems implementing diverse, DEI programs, racial equity training, and I think the jury is still out on the actual impact of those long term. I think that our data showed that, frankly, let me go back. This was like the of highest importance, anchoring care team into the human first approach. Here's some of the recommendations for health systems and for policymakers that these maternal health stakeholders in North Carolina identified. So I don't think it's just as simple as, hey, let's expand racial equity training. Let's expand DEI programs. It's a yes, and there are multiple things that are dynamics that are happening within these healthcare systems that we need to get on top of. So look at some of these recommendations. Better orient traveling staff to local community issues and resources. Multiple postpartum people to me talked about the fact that their nurses disclosed that they were traveling nurses. And a few were okay with that. But when I asked some of the nurse midwives what they thought of that, they were like, I think that's a threat to not have nurses who are grounded in the local resources, the local community issues. And they weren't certain, they weren't confident that the health systems were doing all they could to ground those traveling staff to those issues that may have improved care provided to the postpartum people that we interviewed in the study.
We do have another.
Sorry,
sorry.
Rachel,
Yeah,
did that answer your question?
Yes, it did. Thank you.
And we do have another question from Rosanna Hudson asking about the mortality rates of Hispanic women and why they were so low compared to others.
That's a good question. There are multiple reasons for that. That wasn't necessarily the focus. I can assure you that those numbers, I think from the beginning of the presentation, are from the CDC and they're appropriately weighted. So it's not necessarily that we surveyed less or we captured less birthing outcomes for Hispanic populations. I think the mechanisms are just different.
Now I have a question for you.
Yeah.
Now, as you're serving as a doula, how does the research and the interviews and the conversations that you've had with various women and birthing parents, how does that impact what you do as a doula? Or how does that impact how you engage with other healthcare providers? I'm just very, very curious.
Yeah. That's such a good question. I'm serving two Black birthing people right now, actually, as my clients up here in Maryland. Honestly, I do try to amend the way I approach my doula practice for minoritized individuals, and particularly Black individuals. So, for example, one of my clients has kind of a fear of preeclampsia, a fear of the healthcare system. Good um, she hasn't had good experiences. And so I have to orient the guidance I give in a way that's trauma informed. My role as a doula is so much about making sure that I equip them with the tools that they can use to advocate for themselves in those settings. And so I augment, like I have been in front of that client 6 times prenatally to help prepare them for what's to come. The other thing I do, particularly for minoritized individuals, is because we know from the data that the anticipatory guidance that is provided in general is kind of subpar. I really honed in on maternal warning signs, in particularly in the immediate postpartum period, so that their partners, their mothers, the people around them are aware, and they themselves are aware of when something is normal and when something is not. I also don't, I do this with everyone, but I think I make a special point with the clients I have who identify as Black. I don't glorify pain. So I think in particular, because we know from the data that pain, is not taken seriously. I make sure to be explicit about the fact that I will follow their lead when it comes to, how they want to approach their birth and how they want to implement pain tools, either tools that the hospital has or tools that we have at our disposal. And so I have like explicit conversations around that ahead of time, and I try to provide that anticipatory guidance.
Now, there was a request to see if you can go back to the slides of recommendations. I know there was the go zone slide, and yeah. Sarah, is that the one, excuse me, is that the one that you were referring to?
One other one that we're kind of from the green, the go zone.
Yeah, the go zone.
Maybe one more. For those of us, maybe was there one more? For those of us that are feeling the sense of urgency to make things better, I think it's really helpful that you moved not just to identifying the problem, but to moving towards solutions. So I really appreciate that about your research. And I just find it really helpful that you also kind of got a sense as to where would we want to start.
Yeah.
Yes, and
Go ahead.
I'm just curious, was there one that was a low priority for the birthing parents compared to what was deemed as most actionable? Because sometimes there could be a disconnect where there are great initiatives that sound, because what I love about your work is the recommendations are grounded in the lived experiences of the Black birthing parents themselves, right? It's not just somebody thinking up in the room, this will be a great idea. So I'm just wondering, was there any disconnect that you can recall where some things are often championed that doesn't really resonate with the population, or vice versa?
No, that's a really good question. I think those certainly exist, right? In our methods, I did not capture importance and actionability from birthing people. So when Black postpartum people told me something was important, that made the list. Like there was no kind of gradation of what they were telling us they needed. we did capture discrepancies in, so like assume all those needs are equally important. We capture discrepancies here in the SCO zone of, postpartum needs that were viewed as highly important, but not actionable. So things like, and it was about 5 or 6% of the total kind of list. Things like accessing a mental health professional that looks like me, attending postpartum visits that where I did not feel rushed, attending postpartum visits on short-term notice to address issues impacting my quality of life. We know those things are real. We know those things happen to Black postpartum people, but the maternal health stakeholders, when viewed with those needs, said, these aren't actionable. I'm not sure what we can do here. And so I think these lists, point to potential regulatory and policy policy issues where we can kind of see or enact change. So I did some thinking around potential policy priorities and areas. There's certain, and we can talk about this probably all day, but there are certain things that are happening both at the federal level and also at the state level in North Carolina. And frankly, I don't know that they are well positioned to enact the type of transformative change that we need to see to improve outcomes. So, things like White House blueprint for addressing the maternal health crisis has gotten somewhat diluted to just requiring an attestation by hospitals that they're working on this. Like, yes, but where's the teeth? Where's the accountability? So we've made some recommendations here based on our research, but I think certainly we need to consider when Black postpartum people tell us something is important and the people working on these issues day in and day out say, I can't enact action here. What does that say? What do we need to do?
Thank you for that. So we are going to land the plane, so to speak. Burcu, if you can stop sharing your slides, we have 2 more questions we want to sneak in, and then if we can hang on just a bit to officially end the meeting. One is from Kiara Walsh. She asks, given the stark realities of racial and Black disparities in postpartum care highlighted in your presentation, what actual steps do you recommend for providers or community organizations to begin championing change in this critical area? Can you please share 3 main takeaways that stakeholders can implement to address and mitigate these disparities effectively?
That's a great question. So what I'm happy to do is in my actual write-up, I have a grid of all those recommendations, and we broke that down by from our focus group discussions, we broke that down by recommendations for policymakers and recommendations for health systems. And I think those recommendations for health systems also point to potential areas of both intervention and engagement by community-based organizations. So I'm happy to share that table in its totality after the presentation with this group. But I wish we could hone it down to 3 main takeaways. I'll try. I think that there needs to be we need to find ways of better holding both health systems and policymakers accountable for outcomes in this area. I think that we need to kind of leverage the momentum that we've had in terms of, Medicaid coverage for doulas, Medicaid coverage for the postpartum year. Yes. And what does that mean? We had so many doctors tell us, I don't know what to do with that year. I get reimbursed as part of a bundled fee. I'm not sure what the year-long pathway looks like. Or clinical pathway looks like for most people. And yet we have such poor outcomes. So obviously there's a mismatch there. And I think local community-based organizations, local stakeholders could play a really vital role bridging that gap. They should
Awesome.
fund and let the community groups come in to help if they don't know what that looks like. I 100% agree. And I think there's appetite for that. And yet there's a lot of tokenization that occurs. And so I think this is probably part of the larger conversation around what does long-term, sustained, devoted, and like a trusting relationship between local communities and health systems or health plans look like. And frankly, it's one of the reasons we did the concept mapping study was, an underlying belief that like the local communities hold the answers.
Awesome. Wow. Well, everyone, thank you so much. Burcu, if you can stop sharing your screen just for a
did I
moment
not?
for me.
Sorry.
And no worries.
We also dropped an evaluation in the chat, and it would mean a lot to us if you would fill that out. And if you've also filled in the little attendee link, we will be able to send some follow-up information. And we can also share contact information. Thank you for Dr. Bozkurt. Congratulations again.
Thank you.
It's very exciting to have researchers like you now let loose on the world.
Yes, yes. And so here, for those of you who want to use your phone real quick, you can just use this to grab that attendee information form. And then we also have similarly that form for evaluation. We'd love to hear from you and just get feedback about what you thought about this. And there will be information sent out regarding the link to this video and the things that Dr. Bozkurt will be able to share with us. We want to let you know our next community of practice is on February 12th. We will be talking about the MHLIC partnership, so we hope to see you there. And don't forget that we also do have some new upcoming reels coming up to share with birthing parents, as well as other topics. And the resources are available to order, order any of the resources, the prints available for free. And so with that, Sarah?
I just want to thank you so much for your presentation and for your work. We would love to thank everyone for joining us today. This has been a phenomenal